So we begin with the next TOG article, that is Unexplained Subfertility Diagnosis and Management. This is a short TOG article. So unexplained infertility is diagnosed when couple fails to conceive after 12 months or more of regular unprotected intercourse. The standard investigations are normal, such as there is a ovulation, there is a tubal patency, semen analysis is normal. These particular levels are the parameters you should remember, because there is always a SB on this. Okay. Volume is more than or equal to 1.5. pH is more than or equal to 7.2. Sperm concentration 15 million per ml. Then total count is 39 million. Then total motility is more than 40%. Progressive motility more than 32%. Vitality is 58% or more. And morphology is 4%. So they can ask any of these parameters. The progressive motility, they can ask the total motility, can they ask, or they can ask you vitality or the morphology also. So these values we should know. Then what is the prevalence? Around epidemiology and the prognosis accounts for 30 to 40% of the subfertile couples. Spontaneous cycle fecundity, if you don't treat this infertility couple, unexplained infertility is only 1 to 4% per cycle. The prognosis will depend upon the age of the female, duration of the subfertility, and the previous obstetric history. Okay. So potential contributing factors, the age of the female we have discussed. As the age increases, the oocyte number and qualities will deteriorate. There is increased embryonic aneuploidy. Okay. So women more than 35 years are likely to have unexplained subfertility. Then the smoking, weight, obesity, impaired implantation, alcohol for men more than 5 units per week. Women, it decreases the implantation, leads to the luteal dysfunction, and other factors such as psychological stress, environmental toxins, illicit drugs, excessive caffeine. These are the lifestyle factors which are associated with the unexplained infertility. Then ovarian reserve. The ovarian reserve will reflect the remaining pool of the oocytes. Okay. So what is the most important parameter which is predictive of ovarian? It is the age. Okay. So age is the most important ovarian reserve test in predicting reproductive outcome. If she has got a low reserve, that will indicate that there is a poor IVF response, but does not reliably predict the spontaneous conception. So the low reserve will not predict the spontaneous conception, but it will mean that IVF response will be poor. Okay. AMH and AFC are the best predictors of the ovarian response, but not for the natural fertility. Okay. Then tubal function test. Tubes may be patent, but they may be dysfunctional because subclinical PID, because of the chlamydia, there may be impaired ciliary or the muscularis function. Okay, so, and that cannot be detected by the HSG or the laparoscopy alone. So these are all causes for the unexplained infertility. Okay. So there can be fertilization defect, maybe in the zona pellucida binding or failed acrosome reaction, etc. Implantation defect can be there, and other immunological or genetic metabolic factors, oxidative stress, maybe because of obesity, smoking, alcohol, drugs, etc. So these are the different contributing factors to the subfertility in patients with unexplained infertility. Other is endometriosis. Around 30% of women with unexplained infertility may have mild endometriosis, which is detected only on laparoscopy. Okay, so fecundity is similar to unexplained infertility. Again, medical treatment does not improve the fertility. Laparoscopic ablation may have minimal benefit for these patients, and causative role remains controversial. Then there can be fibroids and adenomyosis. Okay. Now, what are the investigations in patients with unexplained infertility? For ovulation, we can use LH kits, mid-luteal progesterone, ultrasound. Okay. So regular cycle generally is an indicator of ovulation, but cannot assess the oocyte quality. Okay. Then for tubal patency, we have HSG, HycoC, then laparoscopy and dye test, but they will not assess the tubal function. They will tell whether the tubes are patent or not, but not about the function. Semen analysis, WHO reference limits we have seen number, motility, and morphology, but it will not assess again the sperm function. These are the limitations. Then ovarian reserve test such as basal FSH, AMH, and AFC, they are the best predictors of response to the stimulation, but poor predictors of natural conception. If there is a low reserve, advise earlier attempts to conceive. Then you have a diagnostic laparoscopy, but it is not routinely recommended in asymptomatic women. It will be recommended if there is a symptoms of endometriosis or previous treatment has failed or there is a past history of PID or pelvic surgery. Hysteroscopy definitely has got some role, but in patients of submucous fibroid or endometrial polyp. Okay, so if you have got endometrial polyp or submucous polyp, then the hysteroscopy definitely has got a role in assessment of the uterine cavity, and that is a gold standard for assessment of the uterine cavity. Okay, then saline infusion sonography plus 3D ultrasound, that is effective and less invasive alternative. Okay. Treatment of unexplained infertility, core principle is that empirical treatment due to absence of definitive diagnosis, there is no single superior strategy. Management should be individualized and it will depend upon the female age, duration of subfertility, prognosis of natural conception, previous pregnancies, and patient preference. There are this is the management what we have discussed in the NICE guideline, that is the expectant management. Okay, so the treatment is, one is an expectant management, second is a ovulation induction, third is a IUI, and the fourth is a IVF. Okay, so here is a difference between the TOG article and the NICE guideline. NICE guideline has clearly mentioned that it is the expectant management for 2 years, and after 2 years go for IVF. There is no role of ovulation induction. That was the first we started in the first slide in the NICE guideline, and there is no role of IUI. But the talk article says it is an expectant management, ovulation induction with clomiphene citrate, letrozole, or gonadotropins. Third is a IUI with or without ovarian stimulation, and fourth is a IVF. Okay, so this is what is mentioned in the talk. But the talk also clearly mentions the guideline recommendations in 2013 do not offer IUI routinely for people with unexplained infertility or subfertility who have regular unprotected sexual intercourse. Consider IVF after 2 years of expectant management. Okay, so even the talk article clears that NICE does not recommend any ovulation induction or the IUI in these patients. Okay, so the management is a expectant management is first, almost 75% conception rate. It is cost effective and it will avoid unnecessary intervention. Okay. Then tubal flushing is another, but it has got limited evidence. There are two types of media, oil based and the water based. Which one is better? It is a water based soluble contrast that is preferred. Okay, and oil based contrast is less used, and it is mainly because of the granuloma risk and imaging limitations. Okay, so tubal flushing may have a transient fertility enhancing effect, but it is not a primary treatment strategy. Third is a clomiphene citrate. Okay, a NICE guideline does not recommend clomiphene citrate. There is no benefit in ovulatory women with unexplained subfertility. The Cochrane review, there is no improvement in the live birth rates. Okay. Then fourth is the IUI alone. There is no benefit over the expectant management. IUI plus control ovarian stimulation, there may be some benefit, increase in the live birth rate compared to natural cycle IUI. It will correct the subtle ovulatory dysfunction and it increases the availability of the oocytes. Okay, but there is a risk of multiple pregnancy and ovarian hyperstimulation. Okay, risk reduction can be done by mild stimulation protocols, strict cancellation policies, and multiple pregnancy rate is in the range of 10%. We have already mentioned the NICE guideline mentions do not routinely offer IUI. Proceed to IVF after 2 years of unexplained subfertility. Okay, so, but in selective cases, you can go ahead with these IUI and the ovarian stimulation. In selective cases, this is what the talk article says at the end. Okay, so IVF. Now, IVF and ICSI, these are the two things which are available. Okay, IVF has got a higher per cycle pregnancy rate than IUI. Similar cumulative live birth compared with multiple IUI cycle. Success rate is around 30% plus minus 3. Okay, if the age of the woman is less than 37 years. There are certain trials, okay, but early IVF is beneficial. If the age of the woman is more than 38 years, there is a poor prognosis and long duration of subfertility. Okay, and there is something like a IVF with ESET, that is single embryo transfer. comparable live birth rates to IUI plus COH. So if you go ahead with IVF, the rates are similar to IUI plus COH. Okay, it reduces the multiple pregnancy risk also. Okay, so IVF should be individualized and not universally first line. Okay, it is always expectant management first, followed by IVF. And as per the talk, you go ahead with this COH plus IUI in selected cases, and IVF after that. Okay, this is what the this particular article says. ICSI is indicated if there is a occult fertilization failure and previous IVF fertilization failure. There is a high fertilization rate, but there is no proven improvement in the live birth or the pregnancy rates versus IVF. Okay, but it is not routinely recommended for unexplained infertility as supported by the NICE and ASRM. Okay, so what is the expectant management is the first option. Tubal flushing is an adjunct and it has got limited benefit. NICE does not mention anything about clomiphene IUI. Okay, this is what is the NICE recommendation. IUI plus COH in selected couples may be carried out. IVF in older and failed IUI patients, and ICSI is not routine but can be used selectively. Okay, so that finishes the TOG article about the unexplained infertility. Thank you. Doctor, could you get the difference between the NICE article and the TOG article?
Sir, in exam, what should we remember?
That
Nice
is
or
what I
talk?
said. Go ahead first with the NICE. Whatever is given in the NICE, that will be standard.